In recent decades, the improvement of post-operative management and use of fast-track recovery protocols after cardiac surgery has significantly reduced the post-operative hospital length of stay. Ironically, these protocols also increase the rate of unplanned post-operative hospital readmissions. Previous study reported that around 20% of patients who underwent cardiac surgery were readmitted within 30 days after discharge. It is reported that cause of readmissions was insufficient stratification and management of remaining cardiovascular risks and inadequate medication adjustment or physical function recovery. In order to prevent readmissions, recent guidelines show that cardiac rehabilitation has a Class 1 recommendation which effectively improves symptoms and exercise capacity. Cardiac rehabilitation after cardiac surgery was divided into three phases such as Phase 1, 2, and 3. Phase 1 CR was conducted in patient's phase which started just after surgery. Phase 2 CR was conducted outpatient's phase, and this phase encompasses the immediate post-discharge period. Phase 3 CR was maintenance phase, which was an unsupervised program and often community-based program. In three-phase CR, most clinical trials of CR were conducted in Phase 2 as outpatient phase. However, Phase 2 CR is underutilized worldwide. Phase 2 CR was only provided to 30% of patients in Europe, 25% in the United States, and only 9% in Japan. Institutional practices, healthcare systems, and health insurance system practice could explain this low rate of participation. As the rate of Phase 2 CR participation is very low, Phase 1 CR is a very important opportunity to manage patients after cardiac surgery. In Phase 1 CR, exercise-based programs were conducted in many cases. Exercise-based programs aims to return to the LDO, offset the prolonged bed rest effects, decrease anxiety and depression, and determine the effect of prescribed medication during activities. But taking into the consideration of the cause of readmission, we thought that exercise-based CO is not sufficient to prevent readmissions. Therefore, we investigated the preventive effect of comprehensive multidisciplinary Phase 1 CO on unplanned readmissions. Multidisciplinary CO focused on psycho-educational intervention to improve patients' coping strategies, improve disease management, promote self-monitoring of their heart failure symptoms, and help resume daily life after cardiac surgery. Multidisciplinary CL consists of twice-weekly group education and discussion sessions and individualized counseling. The educational programs was offered to the patient and the patient's caregivers as well. In this retrospective cohort study, we divided the patient into the conventional exercise-based CL alone group or multidisciplinary CL group according to the post-operative intervention they had received. In conventional CL group, rehabilitation mainly focused on exercise training and prevention of post-operative complications based on guidelines each weekday for approximately 1 hour. Multidisciplinary CL group conducted an exercise training program plus psycho-educational interventions, counseling, and education component. Flowchart of our study was shown in this slide. We enrolled elective cardiac surgery patients. After excluding patients who did not complete CO, we adjusted for baseline characteristics using propensity score to reduce the risk of bias in treatment selection and other potential confounding factors because patients were not randomly assigned to the CO group. Propensity score matching identified 216 matched pairs for comparison. The main outcome of this study was unplanned readmission after discharge. Unplanned readmissions included any type of emergency readmissions, but planned readmissions were excluded, which was defined as readmissions classified as elective. This figure shows a comparison of propensity score distributions before and after matching between the conventional and multidisciplinary CL groups. The covariate balance in the matched cohort was considerably improved. Results. This trial showed the incidence of readmission. Unplanned readmission was developed in 56 patients. It means 17.2%. Heart failure was more than half of the cause of unplanned readmission in the study. The incidence of readmission in multidisciplinary shear group was 12%, and it is significantly lower than in conventional shear group. This figure shows that the Kaplan-Meier survival curves for cumulative unplanned readmission-free survival after cardiac surgery between conventional and multidisciplinary shear group in a propensity score matching cohort. The incidence of unplanned readmission in the multidisciplinary shear group was significantly lower than that in conventional shear group. To summarize, multidisciplinary CR reduced the incidence of unplanned readmission after adjusting confounding factors compared to exercise-based CR alone in phase 1 CR. Multidisciplinary CR focused on patient education and disease self-management in the early post-operative stage can reduce subsequent hospitalization and improve long-term prognosis. Our results suggest that the multidisciplinary CR is useful regardless of patient's background and comorbidities. We think the multidisciplinary CR education program for patients and their caregivers effectively promoted heart failure symptom monitoring and daily infection surveillance. In particular, we believe that it is most important to educate patients about self-monitoring and self-management of heart failure symptoms. In conclusion, early multidisciplinary CR can reduce hospitalization and improve long-term prognosis after cardiac surgery. Thank you very much for watching.